everyone. Greetings from India. Namaste. Good morning, good afternoon, and good evening, wherever you are in your time zone. Welcome to this CAMS Indian Menopause Society collaborative webinar. I am Dr. Neelam Agarwal. I am this year's international representative of Indian Menopause Society to International Menopause Society. And this session is CAMS Menopause are collaborating Indian Menopause Society with International Menopause Society through Council of Affiliated Menopause Societies. And today's webinar is topic is genitourinary health, and we have three speakers discussing physiology of vaginal health with menopause, genitourinary syndrome of menopause, and how to help those who are cancer survivors and suffering from GSM. So this is an online event which is supported by an unrestricted grant from Abbott. But at the same time, I must tell you that Abbott had no role in the selection of topics or speakers and hasn't vetted or reviewed the contents of any presentation. Speakers have been selected by the Indian Menopause Society and they have got no financial revenue for their today's presentation, right? So I would like to tell you more about the International Menopause Society. So International Menopause Society has many fronts where you can get benefit, like interviews and series giving you different aspects of management. Then journal climacteric, and then it's educational program Impart, which is International Menopause Society's professional activity for refreshers training, and this has two parts combining 8 modules in each part, and this has been designed mainly by our own Dr. Durusha and is a very good and beneficial source of education for the menopausal specialists and those who want to uh, manage menopausal women. So I would request all of you to visit International Menopause Society website. The website is given here at the end of the bottom of the slide, www.imssociety.org, for benefiting from all these activities of menopause. And some other advantages of International Menopause Society: please become members of International Menopause Society, very cost effective membership and with many advantages like 1 year membership and 1 year IMS membership with completion of Impart level 1 free. Exclusive offers are there for IMS members and in partnership with the local societies. So please become members of International Menopause Society. And all the educational activities are free to anybody. Even non-members can access all these activities. So please visit website to get the maximum benefit. So this year, International Menopause Society World Congress is in October, from 19th to 22nd October in Melbourne, Australia. And I would request all of you to visit the website if you want to attend this conference and get benefited. So without wasting much more time, I would now invite Dr. Archana Dwivedi, who is our young, dynamic, menopausal professional expert from Indian state of Gujarat, with many honors and rewards to her kitty. So Archana, I invite you to speak on the physiology of vaginal health with menopause. Archana, please, all yours.
Thank you, ma'am. I'll just share my slides.
And as well.
So I think I'm very much visible on this screen right now on the show mode. So thank you for this opportunity. I'll be talking on vaginal health and physiology at menopause. And it's a proud privilege to be here on this platform with all the stalwarts, because vaginal health is a very important topic and it needs to be addressed because menopause is ahead for all of us. And it is an inevitable truth that it is going to be happening in all the ladies. So if I have to introduce what is female vagina, it is a female genital tract and lower urinary tract arise from a common embryological origin, and both are sensitive to the effects of sex steroids. Vagina is a closed muscular canal extending from vulva to the cervix, and estrogen is the prime factor which determines that no more bacteria grow in a harmful way, because the lactic acid is converted by Dodderlin's bacteria over there and promotes the glycogen formation, henceforth promoting the health of the vagina. The condition of hypoestrogenic syndrome, which was coined in 2014, is known as DSM, which we'll be discussing in the later part of the webinar. It has got a strong negative impact on vaginal health whenever we have a hypoestrogenic condition. Though it is most talked of nowadays, affects most of the women in climacteric phase, almost 36 to 90%. Still, it is a very underrated, underdiagnosed, and undertreated problem in the menopausal era. And the prevalence, as you see in the climacteric, in the premenopausal age, is almost 19 to 20%. So that gives me an important point that why this is happening in the menopause. There can be biological factors, psychosexual factors, and contextual factors when we talk of the ethnic and cultural and the religious expectations which happen with the female. There can be cancer, there can be premature ovarian insufficiency, iatrogenic causes, endometriosis, endocrinal factors, and the perception of the disease, and also the partner's involvement. All goes hand in hand, and we should not forget the economics here. So menopause, where there is a change in sexuality, painful sex, UTIs, tight vagina, dryness, discharge, postcoital bleeding, vaginal irritation, all leading to the female sexual dysfunction. And the only cause is that the vaginal atrophy which occurs. Starting from the point where the vulva IPC, most common examination finding, you can see in this typical picture over here, that the labral fusion does occur. The clitoris becomes less prominent, skin is dry, irritated. Even a slight speculum examination can cause tearing of the delicate tissue. Labral discoloration, darkening is a very common feature. Also the loss of volume and plumpiness, that is we see in the vulva. And if I have to see vagina broadly, you can see in this picture that there is loss of vaginal fornix, atrophy of the labia majora and minora, loss of lugal folds, and decrease in vaginal length. Also reduce flow to the vagina, thinning of the vaginal wall, making it more susceptible to the infections when I compare to the contralateral part over here. So vaginal health is very important because stress, relationship problems, and it does impact the self-confidence of the women as well, because desire of sex, ability to reach the orgasm, fertility, all these issues are very important to address. Unprotected sex, forceful sex, or pelvic injury, health conditions like endometriosis, pelvic inflammatory disease, scarring from any previous surgery, birth control, feminine hygiene products, pregnancy, childbirth, and psychological issues, especially anxiety and depression, which are the first point of mental health, they all in consensus affect the vaginal health. It is just one, not one factor. Look at this beautiful diagram. In a healthy vagina, we have got a basal cells, which represent the germinative center. Then comes the intermediate cells, well arranged, larger, glycogen, which becomes incorporated into their cytoplasm. And as we go on the superficial cells, it is comprised of dead and flattened cell, forming a barrier between the host and the environment, which is very, very important when we talk about. Under the microscope, the vaginal skin tissues look like this. When it becomes atrophic, high nuclear cytoplasmic ratio, and a low maturation value, inflammatory exudates do follow. So here the most important thing is vaginal pH. If I talk of the before menopause, you can see it very clearly in this pictorial diagram I have tried to project, that protective bacteria are happily going on with the low pH. That means the estrogen is present and the vagina is friendly. As we approach the menopause, the vaginal pH shifts towards the alkaline side. The vaginal lining is very poor. The thin film of separation is very, very friable. Estrogen is absent. And that is where the bacteria tends to grow. The protective bacteria are absent. So this is menopause, where decrease of estrogen and progesterone, decrease of vaginal secretions, lactobacilli decrease, vaginal pH increases, and this modification of vagina makes it more susceptible to infections, Also, there is a loss of collagen. Collagen is very important protein, and there's decrease, which is very obviously seen when the lady is in the climacteric phase. Loss of fibrils, chemically high content of hydroxyproline and hydroxyl lysine results in a decreased type of 1:3 collagen ratio, reduced tissue strength, also exposes, this thinning exposes the connective tissue, which is more vulnerable to infection, antibiotic, the microbes, and the infections. And this thinning is becoming more susceptible to trauma. As I said, even a per speculum examination cause the trauma. After menopause, even the urethral mucosa is affected, the collagen content decreases, and there is increase in urethral transition epithelial cells. So decrease in intermediate and superficial cell again causes the burning, micturition, the itching. These are very common findings. A little word about the estrogen receptors, which are present in vulva, vagina, bladder, urethra, pelvic floor, musculature, endopelvic fascia. So all of this is affected, and vaginal health is an accessible and surrogate indicator of low vaginal, low estrogen. So 2 to 3 years post-menopause, vaginal rugosity is lost, breakdown of collagen support, thinning of epithelium, and lack of estrogen. So there is no sustaining of thickness of multi-layered squamous vaginal epithelium. The pink thing is gone, the rugosity is gone, as well as the moisture. Trigone is has a direct effect on detrusor function. The thinning of this does decrease the flow to the urethra and predisposing the women more to the recurrent urinary tract infections along with the vaginal infection. So during menopause, drop in estrogen levels, breastfeeding, surgical removal of both ovaries, POI, chemotherapy, and there are other side effects of breast cancer hormonal treatment which may further add on to the vaginal atrophic changes. So in cumulative effect, you see the weakness of internal urethral sphincter, the infection, the trauma, everything is related and is ultimately leading to the voiding dysfunction or trouble to a lady who is in the climacteric phase. Also, the exogenous causes, surgery, chemoradiation, and smoking, reduced activity, inadequate estrogen replacement, which is our department. We should adhere to the problem, and proper prescription is also as equally important. So, BVA or GSM is, these are the three findings which we have to see when we are looking the patient: subjective dryness, the pH balance, and the objective signs, which are pallor, rugosity loss, and petechial hemorrhages over there. pH again indicates the infection probability in the vagina, and other urogenital pathologies can accompany if there is subjective dryness. So these are few infections which are commonly affecting the vaginal skin: bacterial vaginosis, yeast infections, and urinary tract infections because of dryness, weakness, and the natural defenses lost. Fungal infections are more common with the lower estrogen, itching, burning, redness, thick, and discharging vagina is what the patient comes. Sometimes they can complain of fishy odor, or even we perceive that. Sometimes it is like asymptomatic discharge and itching, which is bacterial vaginosis. So this is a healthy mucosa on one side with abundant amount of lactobacillus, and we have a Gardnerella vaginalis because of loss of the protection of these duodenal bacilli. So this is occurring because multiple layers of parabasal cells with high nucleus to cytoplasmic ratio and few intermediate and superficial cells are present, in which the glycogen content already goes down, vaginal pH is towards the alkaline size, low percentage of lactobacilli, predispose asymptomatic women to a symptomatic vulvovaginal atrophy. Though all studies may not be consistently reporting this association, but it is strongly found in most of the cases whenever there is a drop in circulating estrogen levels. Clinically, we can see that there is, at the vulvar level, there's reduced tissue thickness and loss of pubic hair, scratching lesions, labial agglutination is very common finding, dryness, insufficient hydration, redness, and also consequent symptoms like superficial dyspareunia, which is the prevalence of 78 to 76%. At vulvar level, more frequent symptoms is burning, pain, increased susceptibility to physical and chemical irritants, and mechanical insults, which has been seen in most commonly in the patients. So how do we go about the testing of the pH in the vagina? Wash your hands and dry your hands. Take out the strip from the bottle and then tightly close the lid. Avoid touching the test area of the strip. Insert the cotton swab in your vagina and slowly rotate the swab several times. Rub the cotton swab over the test pad. Enough fluid is important for test evaluation. Then wait for 20 seconds and compare the result with the color chart. This is the self-testing. vaginal kits, which are easily available in the market. And this pH shift is depicted over here. So this is yellow to normal to dark blue, that is 7 pH, which can be easily tested by the patient and the doctors in the OPD. There are certain gloves also which are available. Once you do the PV, the color changes and you can find it out very well. Another important testing parameter is vaginal maturation index, which indicates the degree of tissue maturation, measuring the percentage of superficial, intermediate, and parabasal cells. How do we calculate? We calculate by the formula that percentage of surface cells plus intermediate cells into multiplication of 0.5. This score can vary between 5 to 25 with a cutoff of less than 15 index of atrophic vagina. So vulval health index can be used to evaluate the vulva, including vulval inflammation, musculature contraction, pain at speculum insertion, and epithelial integrity, which can be giving a score from 0 to 24. And here the cutoff is more than 8 index of atrophic vulva. This is a very beautiful chart where you can evaluate your patient for the overall elasticity, fluid secretion type and consistency, the pH of the vagina, the epithelial mucosa, and the moisture which you can find during the examination. So all these scores are very, very important when we talk about, especially fluid secretion discharge, thin yellow, thin white, again a normal white or flocculent type. So this is a flocculent type, is a normal vaginal discharge which is seen, non-friable normal mucosa which turns into a petechiae noted before contact, or a pH less than 5. That is very important finding when we talk about the vaginal health index. Also, there are a few studies which recommend that if you do a transabdominal or transvaginal ultrasound, as you can see in this, you can see the atrophic mucosa of the vagina. Also, the bladder trigone remains a very good indicative for the atrophy to be subjective. And whenever you are putting your patients into therapeutic interventions, it is a good way to evaluate the therapeutic efficiency in our patients with the use of ultrasound. So the principles of treatment remain that we have to restore the urogenital physiology. Systemic topic estrogen therapy is again tailor-made. We have to concentrate on alleviation of the symptoms by using of moisturizers and lubricants. And the prescription is very, very important. We can go with the hormone replacement therapy or skip straight to the husband replacement, which is not an option though. So a little word about probiotics, because capacity of probiotics to colonize the gastrointestinal and vaginal milieu and foster lactobacilli recolonization may provide a natural and efficient strategy for managing the vaginal health during the menopause transition. So they also can be integrated in routine dietary habits, and there are drugs also available, which is typically easier to regulate and having less harmful effects in the long run. And some countries, it is very well serving the patient compliance as well. So to end my discussion over here, I have certain take-home messages that apply topical estrogens on prescription only. Continue having your sexual life, because that is the best way to rejuvenate and regenerate the thermal energy which is created for better vaginal health. And the process of squamous epithelialization, again, strengthening pelvic floor with Kegel's exercises, stop smoking because it can decrease the estrogen and blood flow to the vagina, worsen the dryness and thinning of the tissue, apply vaginal moisturizers daily and at least every 2 to 3 days. Use of lubricants are recommended. And my tips to the patients is that they should maintain the vaginal hygiene. Always wash your vulva from front to back, not the other way, as it may transfer undesirable particles to the vulva and infect it. Don't forget to pat dry after washing, rubbing with a cloth, and prove to be harsh and damp genital area and open invitation to the fungal infection. Use simple running water or a warm water to clean the vagina, but not every time though. Avoid soaps altogether, fancy washes altogether. Remember not to put the soap in the vagina while bathing. Natural secretions do take care of whatever is happening inside. Washing your vulva after urination is a must. After coitus also is a must. Change of underwear is recommended frequently. Keeping the genital area dry as possible to avoid the fungal infection. Avoid douching. Exercise, nothing boosts your immunity and stamina like a good exercise routine. Always eat right. Boost your libido. Perimenopause can sometimes lead to a dip in the libido. Talk to your partner. Find the ways to reignite your intimacies. And regular health checkups, especially annual health checkups, are very, very important, because you need to be diagnosed by a professional expert to help you in a better way. So my 10 commandments to cure your physical health is: eat food rich in calcium and vitamin D, maintain a moderate weight, eat lots of fruits and vegetables, avoid trigger fruits, exercise regularly, eat more foods that are rich in phytoestrogens, drink enough water, reduce your refined sugar and processed foods, don't skip your meals, eat the protein-rich foods that is going to help you in the constructive way. And the 40s may bring some drastic changes. However, these changes are not the ultimatum to the life that is declining. What it signifies is today is the right time to take charge of your well-being. So take steps to improve vaginal health and continue enjoying a healthy and promising life well into your happy life ever after. So I'm thankful to the patient hearing and to the opportunity given to me by Dr. Neelam Agarwal and moderators and Claire and her team. So this is what I needed to talk about. The other treatment part will be covered by my next speaker. So I have tried precisely to talk about the physiology and what we need to know about the vaginal health. Thank you so much.
Thank you, Archana, for setting the stage. So now we move on to our next speaker, and I'm privileged to introduce Dr. Anju Soni. She's the current president of the Indian Menopause Society, and she is the HOD, Obstetric Gynae, Director of Soni Group of Hospitals at Jaipur. She is, of course, a member of the International Menopause Society, which Neelam was trying to urge everybody to be a part of it, and she's already part of this society. And she has held various coveted posts in various organizations, so she's a leader. And then at the academic front, she has edited books, contributed to chapters. But to put it all in one statement, she has received the Wonder Woman Foxy Award. Over to you, Anju.
Dr. Meeta, for your kind introduction. Without wasting my time, I would like to start sharing my screen. Okay. Yeah. So thank you very much for kind introduction. And without wasting any time, I have no disclosures to make. And I'm going to talk about a very, very important topic today, which is genitourinary wellness in menopause. And I always prefer to start with a case, and this is a real-time case. I had a woman who was 54-year-old and a woman who had a menopause at the age of 46. She had hot flashes which resolved by 49 years of age, but her vaginal symptoms worsened with time. She used lubricants initially after taking advice from me, but she was in between, he disappeared. And then later, when she came to me, she said the lubricants were not effective. They used to have a satisfying sex life prior to menopause, but the couple now is engaging only in non-penetrative activities, and both miss the intercourse in the relationship. Now, when I go through my presentation, I'm going to talk about the how prevalent is the genitourinary syndrome, and which encompasses vulvovaginal atrophy, how it is diagnosed, what is the history and examination, what are the treatments available, and are they effective and safe. Dr. Archana has made my life very comfortable. So a patient may have dryness, burning, and irritation. She may have lack of lubrication and discomfort and pain and impaired function. We all know that as the receptors are present at the vestibule, clitoris, as well as urethra, uh, the deficiency of estrogen can lead to all these problems, from urinary urgency to frequency to dysuria and recurrent UTI. And when we examine the patient, we know that we can see reduced elasticity. There is pallor, erythema, loss of vaginal rugae, and tissue fragility. And also, some women may present with all the signs and symptoms. They may be bothersome, but it is always very important and pertinent to remember that she may not account these symptoms. They may not be the sign and symptom may be more, but they may not be bothersome for her, and we need to rule out other diagnoses which can lead to this problem. So when we look at the urogenital system, we know that estrogen receptors, as just spoken, are there in bladder, urethra. They can cause all these problems in the urinary symptoms. When the patient, these receptors are also present in vagina, uterosacral, and levator puberacles, which leads to vaginal wall prolapse. And before menopause, we know that vagina has rugates, and after menopause, it has become very pale, and there is better tropicity of an epithelium when, because of the deficiency of estrogen, there is problem in the closing of bladder and urethra. So the estrogen receptors, which are there in bladder and trigone, and they lead to women can hold urine for a larger time. So with the lack of estrogen, there is decreased sensitivity threshold, there is decrease in urethral closure, and the patient comes with the urinary urgency. As has been spoken earlier, the prevalence is very, very little known to the people. There are many, many reasons to it. Because we do not have a specific criteria where we can diagnose how much is the prevalence. And when we look at the different studies, what we have seen is the prevalence is about 50%. But what is worse about is that only 6 to 7% women get treated. And many women are unaware that these symptoms will progress. They feel, oh, my menopause is over, my hot flashes are over, I will not have any problem now. But they do not understand that this problem will worsen as the menopause progresses, and without treatment. And there are safe and effective treatments which are available. So a very beautiful study done by Agatha and all, and what they said was that when women went for a routine gynecological examination, they had a very high prevalence of GUSM, which was from 65 to almost 85%. And sedentary women were more at higher risk, and vaginal infections were also very, very high in this woman. Another study done by Flippy, they said the women who were incontinent had sexual abstinence, and incontinent women also had a higher prevalence as compared to the women who were not having incontinence. So that was very important. And also the uh, greater urinary, uh, one second. Greater urinary leakage during 1 hour pad test showed, okay, sorry, the greater urinary leakage also had worse sexual function. Now, coming to the another study which showed the problem of the sex in the, what they found was it was affected in all ways, like enjoyment, from starting from enjoyment to the spontaneity of sex to be intimate, and also the relationship with the partner. But this was a very, very huge study. This also encompassed the other symptoms of VVA, like vaginal dryness in 55, dyspareunia in 44, and vaginal irritation. So it is very, very important uh, for all of us to look into these problems, because first of all, we need to make ourselves comfortable, because in our country, because of ethical, because of cultural reasons, we are not in forefront. And most of the time, patient herself does not come out with the history of the sexual problem. So we need to be forefront, asking the women, because that, as we can see in this slide, almost 25% of women had problem with the disturbed sleep, disturbed temperament, and even the enjoyment of life. And they had about 60% women had a problem with the sexual functioning also. So we have to focus and be in forefront and ask the woman about their sexual history when they come to us, even for the other conditions, for routine examination, even in the perimenopausal age group. So this is another very beautiful study which was directed on women as well as the main partner. And what they found was that we were affected not only the woman but also male partner. That led to avoidance of sex, loss of libido, and even avoidance of intimacy. And this, even men felt that they were uncomfortable when they had sex with them. In the closer survey, what they found was that the discomfort due to GSM had affected negatively the relation into almost 60% of the women. So what they found was that vulval and pelvic condition can produce. So when we look into it, similar symptoms like it could be vulval dermatosis or lichen planisis, and these women, we need to see them clinically before we say that they are having problem because of VVA. And also objective examination of genitalia should confirm the presence of VVA and rule out other pathological conditions. And when we look at the pelvic, we see that the pelvic hair are scarce. There is loss of vulval adiposity in majora as well as minora, loss of clitoral protective vaginal surface, as said, has been repeated again and again, thin, pale, no rugosity, elasticity, loss of rugae. Then uterine descent can be there. There can be superficial or pain or discomfort when we put in a speculum, even the smallest, and even digital examination or ultrasound probe. So these all are the symptoms. Then, as I said earlier, that the symptoms, the clinical examination can range from atrophy to loss of moisturizer to rugae to pallor, elasticity. pH again has been very well covered by Archana, leukorrheal, introital stenosis, pelvic organ prolapse, thinning, and other things. So these are few pictorial showing that urethral meatus is almost covered. There is stenosis of introital, there is pallor, there is edema, there is loss of moisture, and vaginal rugae and vaginal wall. And in this, you can see that there is thickening, loss of fat, and labial agglutination, and loss of pubic hair. Then, as has been already said, that there are three very important things which we need to talk about, know about the menopausal health and vulvovaginal atrophy. They are vaginal health index, pH, and measurer index. This has been very well covered. I'm not touching this. To assess the pH, already has been covered that it has to be checked, and this is a maturation index slide. And so we should, when we talk of the minimum criteria, specific symptoms such as the dryness, itching, and irritation and dyspareunia, objective examination, paleness, dry vagina, epithelium smooth, shiny, loss of bouquet, absence of other cause infections, and clinical settings, we have to check all BMI, VHI, etc. to evolve treatment. So it is not important to note that there may be minimal signs despite marked symptoms. So these are different diseases which can show different problems. So this slide I've kept just for everybody to remember that we have to rule out all other problems like lichen, sclerosis, lichen, other things which are there in this table. So what about the treatment options available? That is a mainstay of my presentation. So we all know that there are different types of treatment options available with us. We have activity with a regular vaginal activity, solo partner device, and not intercourse sexual activity. And there are non-hormonal products like lubricants and topical lidocaines, long-acting moisturizer, topical lidocaine, herbal laser and PRP, and hormonal low-dose estrogen therapy, DHA, osmophene, and systemic laser. So when we look on the left, there are non-prescription options. What is a very important point, which I will stress again, pelvic physiotherapy is very, very important. Lubricants are available with us, but smoking has to be avoided. Then we can use local phytoestrogen, oral vitamin D and vitamin E and probiotics have been discussed. But when we look into prescription options, local estrogen therapy is a gold standard along with osmophene, DHA, and non-ablative laser. I'll come to it in the future slides. Now, we can see the whole vaginal structure, and sometime woman may come to us too late, where her vagina is already stenosed. In those cases, we may need to resort to these dilators using lubricants. There are different types of lubricants available. They are very good for reducing friction to be used prior to the sexual activity. The moisturizers retain moisture, and they, when used regularly for several nights per week, they are very effective. They have to be optimally balanced osmolarity. pH and physiology has to be similar to natural vaginal secretion. There should not be any smell, any flavor, because the postmenopausal vaginal epithelium is very, very delicate and can get irritated. Coming to the different types available, there are many available: water, silicone, petroleum, natural, all are used. But the water and silicone are latex safe, can be used with sex, and water is only, they dry very early, so they are they do not have a long-term effect. By silicone are long-lasting, but they are little expensive. Use of petroleum and natural gels like olive oil and coconut are inexpensive, very effective, but they stain bed linen as well as the undergarments. So this is a very beautiful study which was done by our own president, Mr. Nick Penny, Dr. Nick Penny, and he had recommended vaginal lubricants moisturizers used alone with HRT. And in this study, he found it to be very, very beneficial. So these are different studies which have, who have used these gels and different moisturizers, and they have found to be effective initially or in the malignancy cases to be used as first-line treatments. And this is again the same thing which is showing that how they are effective in these women in different forms available. So another very important thing is the herbal products, a systemic review which showed that administration of topical isoflurane on vaginal atrophy had been beneficial, and this are very, very effective, and more RCTs are required. Now, coming to laser therapy, they are available in first generation as microablative carbon dioxide laser for epithelial resurfacing. Activities like heat shock proteins activates growth factor, increases vascularity, collagen, extracellular matrix, thickens the vaginal epithelium. They are given in the dose of when we talk of the Weisig laser, they can be used as a photothermal therapy for treatment of GSM. It can be given in the sequence of low fluences, sharp ABM pulses, and it distributes heat in 100 micron. And it also has a controlled tissue healing and is considered to be safer and less harmful. And it is an harmless procedure set as no carbonization is there, and it is said the perforation risk are like urethra, bladder are avoided. But this is one study where in Australia where they compared with the laser and a sham treatment, and they found that both patients had almost similar results. So a lot of further studies are required. But when we talk of FDA warns against use of energy-based devices to perform vaginal rejuvenation and vaginal cosmetic procedures, and they say that these are not to be used and they do not improve the menopausal atrophy, incontinence, sexual function. There are risk of complications like vaginal bursts, scarring, chronic pain, and pain during the sex. Another newer adjuvant with us is the PRP. We have been using PRP for many other things, for skin, for ovarian POI cases, ovarian failure. These are a brand new revolutionary treatment, specifically increase the collagen production, create voluminization of labia majora, and harness thread technology, and help in improving the appearance of intermediary areas and tackle the uncomfortable vaginal issues. We know that PRP contains many growth factors like PDF, TGF, etc., which releases platelets and have an important role to inflammation reduction, angiogenesis stimulation, and collagen. So what they do is they isolate PRP, inject in the introitus and in the vestibular area after the laser, or mixed with hyaluronic acid, fat cells are also put and then injected into the perineal raphe, vestibular fossa, and labius minus and minor. So what they found in this study was that when they used it, the woman had improvement within one month in total VHI scores, and also had improvement in burning, hurting, being irritated, and discharge, desire to be intimate, relationship, almost everything improved within 1 month. So it is for the women who are having a problem in malignancy, it can be a good option for those women where this treatment is going to help us in future. Now, coming to local estrogen, it is estrogen in a low dose. It is a gold standard and mainstay of treatment for not only dryness, vagina, but other urogenital symptoms also. We know that in the absence of estrogen, there is a low, it leads to lower pH, thickens the vaginal epithelium, also increases superficial cells, increases subepithelial capillary growth, and alters the local microenvironment. It is available in many forms, from creams to rings to tablets and inserts. In our country, the rings are not very easy available. Some of our patients get it from abroad, and they feel they are very to be used only once in 3 months and feel them to be very comfortable. And so we must start the therapy before the changes are irreversible. So as just to reiterate that the advantage of creams is that it can be used in flexible doses, but patient may use higher dose. So we have to think that the patient who has got malignancy should not be prescribed cream or should be given clear instruction. Some people feel that vulvar applications are helpful, but we really don't know whether it is absorbed from vulva or it's just the cream effect. Then when we come to talk of tablets or inserts, they have to be used twice weekly. The best advantage with them is that they are a fixed dose. And coming to the estrol ring, only problem is that it requires insertion and removal, but once given, it's safe for 3 months. So a big study on Cochrane base said that there is no evidence in a difference in efficacy between the various intravaginal estrogenic preparations when compared with each other. And there is also no evidence of difference in overall body of evidence in adverse effects between the various estrogenic preparation when compared with each other. This is because this slide shows that when patient is not given any treatment, the serum levels are as low as 4.4 to 5, and when used in a low dose in either form, cream, tablet, insert, or as 4 milligram or 10 milligram, or a ring in a low dose, the serum estrogen level are almost as non-treatment level. But if given for other problems like vasomotor symptoms, in a higher dose of 50 to 100 milligram, the serum levels raise to higher level. So again, when they used low dose estrogen, what they found was that it was not giving any problem in all these cases, from MI, stroke, PA, DVT to all malignancies, and we can safely use these drugs. And when they compared in a study the estradiol and the moisturizers and non-treatment cases, they found the lubricants, they found that they all had improvement, but with the estrogen, all groups had reduction in severity and bother symptom with improvement in FSFI score, but with estradiol, the significantly improvement was seen in MEN-QOL scores and sexual function domain in the cases. And in this slide, we can see that it is available in the composition of all the these tablet, congenital estradiol, estriol, and what they found that when given in the minimum dose started and the serum estradiol levels were almost, low, and the low dose was not giving any kind of systemic problem. So just to reiterate the whole thing, make it to a capsule that low dose is not at all harmful. And another, except for the malignant cases, this is a drug where we cannot use estrogen like in cases of cancer, which Dr. Asnaf is going to cover. This is a newer drug with us, DAHA, which is available in 6.5 milligram vaginal insert. It is also approved by US FDA for mild to moderate dyspareunia. And it is a steroid which is biosynthetic pathway to testosterone and estradiol, and it is a short-term clinical trial showed that there is improvement in GSM in all the parts, including dyspareunia, pH, and maturation index X in 3 years. Effects are seen within 7 days, and it exerts a by local conversion to testosterone to estradiol, and it is a safer alternate to estrogen procedures for the malignancies. So in this, they have used in the 2 doses, 50 and 100, and they found it to be beneficial. Another drug which is available with us is a third generation SERM, osmifene. It is ER agonist to vagina, partial agonist to uterus. It is agonist to bone and neutral to angiogenistic breast, and it is selective ER agonist to vulva and vagina. And in the clinical trials, they found it to be very helpful in moderate to severe cases, and it is given in the dose of 60 milligram for 12 weeks. And when they compared it with placebo and 30 and 60, they found that the effect was improvement was there with in the dryness as well as dyspareunia when they used in the dose of 60 to 30 or 60 milligrams. So osmofene is very, very effective for dyspareunia, and it also shows the both in objective and subjective findings, and also has a beneficial effect in the bone also. So it is a drug which we are waiting for more work to be done. Coming to testosterone, it is available in the gel form in 150 to 300 microgram. It relieves the symptoms, increases the VMI, decreases the vaginal pH, improves in FSFI scores. There is no significant increase in systemic estradiol or testosterone level. So it can be used in the breast cancer survivors who are on AI. However, more studies are needed. No currently available low-dose testosterone local preparation has been approved by US FDA. So we have limited clinical application at the moment. Another very good drug which is in our armamentarium is intravaginal oxytocin, which is available in the dose of 400 or 100 international unit. It increases the VMI, decreases the pH, relieves the symptom. There is no increase in endometrial thickness, still needs further studies. So GSM, to conclude, GSM adversely impacts the health and quality of life of men and women in midlife. It is often unrecognized and untreated. There are effective and safe interventions available, including lubricants, moisturizers, low dose vaginal estrogen therapy, vaginal DHA, osmofene pelvic physiotherapy. Low dose vaginal estrogen therapy generally does not increase systemic hormone levels with anticipated high degree of safety. So before ending, I would like to say that we all need to come together and help these women in giving the unspoken miseries which they are going through. So this is from one of my patients who said that she wants to thank me for the care I have given her with compassion. So thank you very much for patient hearing.
Thank you very much, Dr. Anju, for your lucid presentation and covered everything in a short time. Now I would like to introduce, and I'm privileged to introduce Dr. Asna, who is a young, dynamic menopause specialist from Lucknow, India. And she is also a member of Midlife Registry and Education Committee of the Indian Menopause Society. Asna, stage is to you to talk about GSM in post-chemo and radiation therapy and cancer survivors. Nowadays, this is the present trend, many of the things we are seeing. So the stage is for you, Asna.
Thank you, Dr. Ambuja, for that kind introduction. Thank you, Dr. Neelam, for giving me this opportunity. And it's a privilege to be a part of this collaboration. And my sincere thanks to the International Menopause Society and CAMS. So my presentation today is on genitourinary syndrome in cancer survivors. And I will try to build on the very valuable presentations of my previous speakers. There is no conflict of interest and I have nothing to disclose. These are the contents of my talk. And in 2016, a 37-year-old patient had come to me with a very hard, painless breast lump, and I had referred her to the tertiary center in my city, where she underwent a mastectomy, which was followed by chemotherapy, and she had become amenorrheic after the third cycle of chemo, and her cancer was found to be ER/PR positive, and she was on tamoxifen for 5 years. She was referred back to me for excessive vaginal discharge, and it was an endocervical polyp that I subsequently removed in 2022. And around the same time, after 5 years of tamoxifen, she was put on letrozole by her oncologist. And since then, she has been complaining of dryness of vagina, loss of desire, and painful intercourse that greatly impacts her quality of life. pelvic examination reveals signs of vulvovaginal atrophy. And this is a common scenario, and we as gynecologists are often at the forefront dealing. We have to deal with these kinds of survivorship issues. Globally, 9 million women are diagnosed with cancer each year, and this is from the Lancet's latest series on dealing with menopause, managing menopause after cancer, which was published in 2024. And the improvement in survival rates in recent years means that more women are now living longer after their diagnosis and experiencing long-term effects of cancer treatment. And the commonest cancer in women worldwide is breast cancer, followed by colorectal cancer in the high-income countries, and cervical cancer in low-income countries. And the 5-year survival rate of breast cancer patients is now as high as 90%. So a cancer survivor is any person with cancer starting with from the moment of diagnosis. And cancer survivors have to undergo an accelerated transition to menopause because of the treatment, which can be a bilateral oophorectomy, radiation therapy, especially pelvic radiation, or gonadotoxic chemotherapy, which all lead to premature ovarian insufficiency and menopause. And endocrine therapy, which is the standard of care for breast cancer, it can be tamoxifen, which is given in premenopausal patients for about 5 years, or in the form of aromatase inhibitors, which are given for postmenopausal patients up to 10 years. So all these therapies lead to a faster transition to menopause and severe menopausal symptoms. And urogenital system is particularly sensitive to estrogen deprivation. We've seen in the previous 2 talks what GSM is, and GSM is more prevalent and more severe in cancer survivors than it is in the general population. My slides are not moving. Okay. So unfortunately, vast health disparities exist in the world, and huge evidence gaps are there in research. The rates of treatment-induced menopause are higher in lower and middle-income countries, where the average age of cancer diagnosis is 40 to 50 years, compared to 62 to 66 years in higher income countries. And in these settings, younger premenopausal women are exposed to cancer treatment. And therefore, prevention and management of treatment-induced menopause is an unmet need in these lower middle-income countries. There is also a scarcity of high-quality research from these countries. And even in the higher income countries, the studies that are there are predominantly on overwhelmingly white study participants. And these studies usually lack racial and ethnic diversities, which limits their generalizability to the world population. And most of the clinical trials have been done in older women, and therefore younger patients with cancer can experience severe symptoms and worse quality of life. And most of the published studies are on breast cancer, and we know less about other cancers and the effect of menopause and GSM in women suffering from other cancers. So GSM is often underestimated and undertreated in cancer survivors. And one of the main reasons is underreporting by patients. We are aware that cancer survivors are usually very hesitant to talk about their vaginal and sexual health. And on the part of the healthcare providers, there is a lack of awareness. There can be a poor familiarity with the various available options. And this can be also because of a fear of breast cancer recurrence due to a paucity of evidence about safe and effective therapies. And therefore, the lack of treatment, since it is undertreated, there is a progressive worsening of GSM. We all know that it does not get better with time, like vasomotor symptoms. So the treatment, the decision to treat should depend on the receptor status, the genetic traits, the extent of the disease, time since diagnosis, and the treatment should be individualized, taking into account the patient's various traits like the risk of recurrence, the severity of symptoms, the comorbidities that the patient has, and her personal preferences. And the aim should be to provide an evidence-based information to the patient to help her make informed decisions. We are all aware of the lifestyle modifications, and they've been dealt with in the previous talks. Regular sexual activity should be emphasized, and the mainstay of treatment for all cancer survivors is non-hormonal therapy. It is also considered first line in individuals with a history of estrogen-dependent breast cancer. And we know that non-hormonal options will not reverse the atrophy that has already happened, but they will provide symptomatic relief. Trials of multiple options may be needed before the most effective treatment for that individual patient is decided upon. And there is insufficient data at present to indicate that one approach is superior to the other. So this is a comprehensive list of the therapeutic choices for GSM in breast cancer survivors, and some of them have been highlighted by the different guidelines. This is the ACOG Clinical Consensus of 2021, and various studies have found that silicone lubricants were more effective for sexual pain in breast cancer survivors on aromatase inhibitors than water-based lubricants. Hyaluronic acid moisturizers have been quite extensively reviewed, and they have been found to be effective, safe, and well tolerated. And 4% aqueous lidocaine was found to be very effective to reduce introital pain with vaginal penetration. And in an RCT, it was found that it reduced dyspareunia by 88% if it was applied 3 minutes before vaginal penetration. So we also have vaginal vitamin D and E suppositories, and they have also been studied in an RCT and found to be effective in women with breast cancer who were on tamoxifen. Oral and vaginal probiotics have also been studied extensively. There was a study by a randomized placebo-controlled trial by Julian M. Et al. In 2017, and they found that orally administered lactobacillus preparation has the potential to improve vaginal microbiota in women undergoing chemotherapy. So that brings us to laser. Laser was discussed by Dr. Anju, and it seems to be a very promising modality of treatment for patients, for cancer survivors. And this was a systematic review published recently in August 2023. They included 20 studies and more than 700 breast cancer survivors who were treated with either carbon dioxide or erbium laser. The duration of follow-up was 4 weeks to 24 months. And the available data are reassuring in short term and indicate effectiveness of both carbon dioxide and erbium lasers on the most common GSM symptoms. However, further studies are mandatory to establish long-term efficacy and safety in menopausal women, including breast cancer survivors. And till now, most of the studies were observational. They were short-term studies with very small sample size. But recently, 2 RCTs were also published on the use of lasers in cancer survivors. In 2021, a randomized sham-controlled trial of vaginal laser for GSM in postmenopausal women, half of whom had history of breast cancer, concluded that treatment with fractional carbon dioxide laser versus sham treatment did not significantly improve vaginal symptoms after 12 months. And in 2023, another randomized trial of carbon dioxide laser on sexual function in survivors of breast cancer receiving aromatase inhibitors showed no statistically significant benefit over sham laser. And the Managing Menopause after Cancer article in Lancet, recently published in 2024, also stated that the efficacy of vaginal laser is uncertain. And Dr. Anju also told us that it is not FDA approved till now. So that leaves us with hormone therapy. And it is the hormone therapy is feasible if non-hormone therapy fails to provide relief to the symptoms. And I will not be going into the details of the different formulations. These are the ones that have been that have made it to the guideline, the ACOG guideline for treatment of patients with a history of estrogen-dependent breast cancer. And some of them may not be available in different geographical locations, but the main aim is to use the lowest possible dose of hormone therapy, vaginal hormone therapy, because we now know that vaginal estrogens are systemically absorbed in small amounts, which are dose dependent, and therefore low and ultra low doses lead to low or no measurable absorption. And vaginal estrogens now seem to be safe for most patients with cancer, with the growing evidence that is there and that we will look into shortly. And the most important thing here is to involve the medical oncologist of the patient in the decision making when considering the use of local hormone therapies. So till now, till about 2 years back, there were only observational studies about the use of vaginal estrogen therapy in cancer survivors. But in the last 2 years, there have been 3 significant studies. The first one was this Danish observational cohort study published in 2022. They included 8,461 postmenopausal women who had not used any hormone before their estrogen receptor positive breast cancer diagnosis. And 1,957 of these women used vaginal estrogen therapy, and 133 used menopause hormone therapy after diagnosis of breast cancer. So the median follow-up was 9.8 years for recurrence and 15.2 years for mortality. So they found that neither vaginal estrogen therapy nor menopause hormone therapy was associated with increased risk of recurrence or mortality. Another significant study came from the from the investigators at the Johns Hopkins Institute. They identified more than 40,000 women from a US claims database with GSM after breast cancer diagnosis, and 5% of these women received vaginal estrogen, and they found that no significant differences in recurrence-free survival was there between the vaginal estrogen group and the no estrogen group. And at 5 and 10 years of follow-up, the use of vaginal estrogen was not associated with higher all-cause mortality. And even among the ER positive tumors, the risk for breast cancer recurrence was similar between estrogen users and non-users. And the latest study published in 2024 is a large UK registry-based study of more than 49,000 patients with breast cancer, and 5,000, and they also looked into 5,795 breast cancer specific deaths. They found that 5% of the patients with breast cancer used vaginal estrogen therapy after their breast cancer diagnosis. And in vaginal estrogen therapy users, compared with non-users, there was no evidence of a higher risk of breast cancer specific mortality. So these three, the findings of these 3 studies can provide some reassurance to clinicians who want to prescribe hormone therapy, with local vaginal hormone therapy to their patients. And they also support the guidelines that the vaginal estrogen therapy can be considered as a form of treatment when non-hormonal treatment has failed to provide relief. If vaginal estrogen is not an option, vaginal DHEA or testosterone may help with dyspareunia and improve the vaginal tissue health. And an RCT also showed that DHEA improved, it caused an improvement in the vaginal symptoms, but that it was not statistically significant as compared to the moisturizer, to the plain moisturizer. And this was in 2018, but in 2022, a pilot study published in the Climacteric showed that there was a significant improvement in vaginal health when Prastron was used in cancer survivors who were on aromatase inhibitors, and the serum estradiol levels remained at low levels. So there is another option of the orally administered selective estrogen receptor modulator, that is ospemifene, and there is no indication that it is associated with an increased risk of recurrence, and higher patient satisfaction and adherence is there when compared to other local therapies. But long-term safety data are limited, and it may be considered as an option for individuals with a history of estrogen-dependent breast cancer. So this is a summary of the different guidelines of the different societies, and I have tried to just list them here. I will not go through each of them. I will just read the most recent one from the British Menopause Society, which says that vaginal estrogen can be used in women taking tamoxifen, but not on aromatase inhibitors. And just a few words about patients of cancer who are undergoing radiotherapy. We know that the vaginal effects of radiotherapy are more severe than the effects after chemotherapy. Radiotherapy can cause severe vaginal dryness, fibrosis, and shortening, and that can present as severe dyspareunia and impaired sexual function. So the treatment options are very limited. And vaginal dilators are one of the options, and the patient should be counseled to use these dilators. They are graduated according to size, and they can help in stretching the vaginal tissues. But there is no evidence to support their use, and the uptake also is only 25%. There was an RCT that showed that the use was not, it was not very well accepted by the patients. Vaginal estrogen therapy has also been prescribed after radiotherapy, but there is the evidence to support its use is also lacking. Pelvic floor muscle relaxation exercises have been found to be effective if they are administered by a trained physiotherapist, because radiotherapy can cause severe spasm of the pelvic muscles, and pelvic floor exercises may help the patients. And laser therapy is still controversial because we know that radiation can damage the vaginal mucosa, making it thin and fragile. And a vaginal laser can potentially increase the risk of a rectovaginal or a vesicovaginal fistula. And therefore, more evidence is needed before carbon dioxide vaginal lasers can be recommended safely in gynecological cancer survivors for the management of GSM. So to conclude my talk, in cancer survivors, GSM is one of the main causes of distress and reduced quality of life. Mild to moderate symptoms can be treated with non-hormonal options. If non-hormonal treatments have failed, after discussion of risks and benefits, low-dose vaginal estrogen therapy may be used in breast cancer survivors, including those on tamoxifen. And for patients who are on aromatase inhibitors, low-dose vaginal estrogen therapy can be used after shared decision-making between the patient, the gynecologist, and the oncologist. And large, high-quality clinical trials with longer follow-ups are needed for emerging treatment options such as vaginal laser and some of the newer drugs. And the aim should be to ensure that all healthcare providers and cancer survivors are fully informed to effectively address the impact of GSM post-cancer diagnosis. And even though this may sound like an oversimplification of a very complex issue, but I would still say it, the first step is to ask the cancer survivors, ask your patients about vaginal and sexual health, acknowledge the elephant in the room, recognize genitourinary syndrome of menopause, and offer evidence-based existing treatment options. Thank you very much for your patience. That will be all.
Thank you. Thank you, Asna. So it's now time for the question and answer. I would like to thank all the speakers for a complete overview on different aspects of the genitourinary syndrome, and especially the breast cancer, which is definitely on a rise in India. So we are going to see more and more women, younger women, like Asna has said, with this problem. So your talk definitely boosts the scenario of where, we are very stuck up with the use of the vaginal estrogen therapy in breast cancers, even if they are ER negative. So, but before I pose a question to you, there are two questions that have come up. And so one is a very general question. Is there a prophylaxis to prevent sudden spurt of urine when laughing? So probably not directly related.
Can you repeat, please?
I think Dr. Anju can take
Is
it.
there
Yeah.
a prophylaxis?
You
Is
are
there a prophylaxis to prevent sudden spurt of urine while laughing? So what does the prevention say for your?
So basically, it is a stress
very
incontinence.
quickly,
Yeah, it's a stress incontinence.
yes,
So we need to treat stress incontinence.
correct.
Rule out
So we leave it
UTI.
Yeah, correct. So we leave it at that because it's not directly related. But you could simply say that therapy probably would, being conscious as to how to hold up your muscles when you have that urge. I think would really help.
Would
So,
require bladder training and
pelvic.
would require bladder
Yes.
training and pelvic floor exercises.
Absolutely.
And weight loss would help.
Yeah.
Your voice is breaking.
The next question is
Dr. Meeta, your voice is not clear. Dr. Meeta, your voice is not clear.
Yeah. So the next question is on the OTC products, the vaginal cleansers and the pH balance lotions. What is your take on it? Who would like to take?
I will
Yeah.
take this.
Yeah.
I would take this, madam. A big no to all the fancy items which are available over the counter. Because see, whatever secretions they are coming naturally from the vagina, they are able to balance the pH and take care of the inside flora. So we don't need to disturb that by intervention of unnecessary soapy things or deodorants, because we are destroying the dodal bacilli over there, which are actually very helpful in conversion of glycogen and maintaining the pH of the vagina. So if you start using such products, OTC, just fascinated by the ads and everything, you're actually doing more harm to your vagina rather than doing good to it. You are becoming more susceptible to the fungal yeast infections. So a big no to that. I mean, any senior can advocate something else also. That is why I discuss the role of probiotics also, because we are actually disturbing the biofilm which is already present. So you don't need to do that. Thank
So
you.
as some of the this lactic acid washes which are available, they recommend vaginal washes that those should also be not used. There
Cool.
should be no to any vaginal douches also. So
Yes, ma'am.
that is a
Perfect.
very important take-home message for each and everyone, that no douching, vaginal douching of with any of the OTC products available.
Yeah, thank you. Thank you for that. So I have a question for you, Asna. So supposing now at your clinic, you have this young lady with the breast cancer survivor and ER positive, and with the scene that is around and the stress about hormone therapy and its relation to breast cancer, what would you personally do? How would you handle it?
So if she's on tamoxifen, I will start her on a very low dose of local vaginal estrogen therapy. But if she's on letrozole, then I will not give her vaginal estrogen therapy, and I will just give the non-hormonal options.
What
So,
I would like to say,
yeah.
that initially start with lubricants and moisturizers.
Mhm.
Lubricants before sex, and later, if it is not effective, ultra low dose local estrogen therapy is the gold standard. It can be used in most of the cases. So that should be used. And then, of course,
Yeah,
only problem is with the AIs.
now, I would agree with Anju. So,
Yeah.
first you start with the moisturizers, and then
Yeah.
if it doesn't improve, then your estrogens have to be, the last choice, and that too in consultation and counseling, like you've been saying.
And ultra low
Yeah.
dose.
Just need the long-term data to back
Yeah.
up what you're
Yeah.
writing.
Yeah.
Yeah. So,
Yes.
And ma'am, I would like to add one thing. Pelvic floor exercise in
yes,
every patient,
absolutely.
everyone from perimenopausal and menopausal age is very, very effective. What I have seen, that the women who are active, who go for even brisk walks, suffer from GSM much less as compared to the women who are sedentary. So we must tell our women about physical activity. And of course, sex life is also very essential. So physical activity and physical pelvic physiotherapy, as well as regular sexual activity, all three are very, very important for the women who are having prone to GSM.
Yeah,
Or
adding
even
to that,
non-hormonal.
adding to that, what Anju madam has correctly said, that Kegel's exercise or pelvic strengthening exercise is important, but we need to educate your patient. You do contract the muscles, but don't forget to relax them, because 8 seconds of relaxation is very, very important. To unnecessary stretching of the muscles doesn't occur. We always say that you do the contractions, but do not forget to reinforce that equally important is to uh, relax the muscles as well. Thank you, ma'am.
Neelam, would you like to take it forward? There are two more questions, I think, with chat box.
Yeah.
I don't
Yeah,
know
there is
if you're
a
keeping time. Yeah.
Yeah, there is a question about antifungal drugs in recurrent vaginal infections, especially in diabetics, even if the sugar is controlled. So, who will like to take it up?
Archana, you want to take it?
I'll take it, ma'am. So the market is flooded with vaginal pessaries, and the recurrent fungal infections or candidiasis or yeast infections have become a common scenario nowadays. So stepping further to what is available nowadays is fenticonazole, which is very good. So personal hygiene, as I said, tips of hygiene should be maintained. And fenticonazole insertion of vaginal pessaries on the first day and the third day has been found to be helpful. There are market also flooded with lots of itraconozoles and other upgraded versions. But I think we should be very judicial in prescribing the oral antifungals, because we don't want to destroy some fungus which is really required for the gut flora and everything. So I think judicious use of antifungal treatment available would help our patients in a maximized way. So fenticonazole is something which has come up in a good way, and if we don't do a medical abuse to that, judiciously, probably we'll have a better situation in future.
Treat the partner and treat it for a longer duration, and also control the diabetes. 3 points
It is
I
a
want to add.
question that can retention of urine be a symptom?
Ma'am, समझ में नहीं आ रहा.
Yes, ma'am. Yes.
Can
Yes,
retention be a symptom?
Perfect, yes, madam, to that, because the urethral opening becomes a little narrow in the climacteric phase, I would label. Now, younger ladies are also coming with that. So that is a very important system, that there is a stream is reduced and the frequency, you feel the urge, but when you go to pass, the stream doesn't come as before. So many of the clinical trials and many of the patients who come in the OPD, by simple urethral dilatation also, they're getting help. But when we work in unison with the urology community, we find that low dose of estrogen, as Meeta ma'am and Anju ma'am has already said, along with urethral dilatation and bladder training, would help these patients. So if a patient comes in your OPD with the symptom of urine retention, please do not ignore it.
Yes, Archana, you are very correct. But at the same time, exclude urinary tract infection, because retention can be there with a UTI infection. There is one more question. Anybody has got experience of topical isoflavons?
I have used it.
I have used it, madam.
Yeah.
So what I have done is that when a patient comes to me with GSM, I initially treat them with the low dose estrogen local application, and once the patient is symptom free, so then I shift them to the isoflavin, and it is found to be effective.
Yeah, so
But
we
initiate with
don't
the
have any.
low dose estrogen and then maintain on them. That is what I have used, and many patients, and I found it to be effective in my clinical practice.
I think it may be a last question. Vaginal vitamin D commercial preparation, ma'am. Anybody knows about it?
No.
What, ma'am?
Because I had not used.
Maybe Dr. Meeta knows about it. I have no idea. I have only seen
No, we
people.
don't have,
Not
we-
available in
we
India.
don't have
any.
Not available,
local
yeah.
preparation available
Not
in
available.
India, but we do
Not
have
available.
isoflavone.
This
Isoflavone
vitamin E and D are
yeah.
all oral preparations. And
Vitamin E, I have seen people taking orally, not vaginally.
Yeah.
That's right.
Vaginally, lot of people, when they are near fertility, they want to have fertility, they are using this coconut oil, olive oil in Italy. So a lot of people are using these oils, and they find it to be quite.
Meeta, do you agree this? Postmenopausal people, we should not use coconut oil because it increases the candidal infection. So this is not advised in the postmenopausal people.
Glycerin. True,
Yeah.
ma'am. Anything which has gasoline and glycerin content. I'm not sure about the coconut oil, but the content, it can precipitate your yeast infection. So we should be avoiding it.
Yes.
But
I think we have had a very excellent session. All the speakers have deliberated comprehensively, and I think all of you must have benefited from their talks and experiences, and no postmenopausal woman should suffer from GSM or the other.
In silence.
Yeah,
in
silence.
Finally,
So we have to
Dr.
be
Neelam
proactive.
and CAMS, Dr. Neelam and CAMS for giving the opportunity, and thanks to Meeta for joining with us and giving her precious opinion. Thank you, all the speakers.
Thank you. So
Excellent
we
job.
conclude this session now. I think it's time to go. Every good thing has to come to an end. Thank you very much. We conclude the session and hope to see you again in some other CAMS session. Thank you so much. Thank you.
Thank you. Good night.
Yeah.